Good day everyone. Today is our third lecture of COVID-19 and kidney diseases patients. This lecture will be presented by Dr. Zeyad Abdelgawwad al-Husseini. He will touch base on the management of general nephrology patients that include hypertension, management of immunosuppressions and kidney transplantation. Thank you very much.
Good morning. My presentation today, which is titled COVID-19 and the Kidney, a Practical Approach, will focus on how to deal with chronic kidney disease patients in the era of COVID-19 pandemic, and also how to manage the dialysis inpatient service through the outbreak. SARS-CoV-2 infection is posing challenges to all the health system in the world. The ideal therapeutic approach is still debated, and data on subgroups of patients at high risk is still scarce. Successful management of COVID-19 outbreak will demand flexibility, collaboration, and shared responsibility across the continuum of care. What we don't know actually is a lot more than we know. Clearly, we have much to learn about this virus, and the learning curve will be steep. We will benefit from the experience of nephrologists in countries that have already seen a greater share of COVID-19 infection, and we hope that we will not build our own experience in Kuwait. So my agenda today will speak about management of kidney patients with focus on chronic kidney disease patients, especially those with hypertension and those who are receiving immunosuppressive medications, because those are among the high-risk groups for catching the infection and for the deterioration of the condition, and also for mortality. Also, brief talk about the transplant patients, and finally we will speak how to manage the inpatient dialysis service through this outbreak. CKD patients. We know that the comorbidities associated with increased mortality during COVID-19 are common in CKD patients. And CKD patients are unique in view of their immunosuppressive status. This figure shows us in this paper published in the Kidney International Journal last month, illustrating the kidney disease associated with in-hospital death of patients with COVID-19. And we can see from this figure that the kidney disease associated with increased incidence of in-hospital death in patients with COVID-19. And this goes with all subgroups of kidney disease patients. For instance, in acute kidney injury stage 1 doubles the risk of mortality. And if the patient developed acute kidney injury stage 3, it quadruples the risk of mortality. So how to deal with CKD patients on immunosuppressive medications? We will talk about prevention, also how to deal with newly presenting or relapsing nephrotic syndrome in this outbreak, and what about patients who are already on maintenance phase of immunosuppressive medications, and what to do with suspected or confirmed cases regarding the modulation of the immunosuppressive medications. The UK Renal Association guidelines actually published recommendations regarding patients on immunosuppressive medications, CKD patients I mean, and they are categorizing the patients into 3 groups: high risk group, intermediate risk group, and low risk group. For the high risk group, they advise that the patients self-isolate for at least 12 weeks. And for the intermediate risk groups, not currently advised to self-isolate, but may be moved in the group 1 at later stage. For the low risk group, they don't require self-isolation in the first instance, but should follow all the hygiene measures and social distancing. The high-risk group include most of our patients on immunosuppressive medications, as those currently receiving intravenous induction immunosuppressive medications, those who are currently receiving cyclophosphamide orally, or patients receiving steroids for 20 milligrams per day for more than 4 weeks within the last 6 months. And also to be mentioned that among the high risk group, that patients with CKD stage 3 or above, whether they are receiving immunosuppressive medications or not. For the group 2, which is intermediate risk, those with well-controlled disease activity and no comorbidity who are on a single oral immunosuppressive drugs, those known to have low IgG levels, even if not currently in immunosuppression, and those who, despite complete biological induction treatment more than 6 months previously, remain B-cell depleted. And finally, patients who, despite achieving disease remission, remain on maintenance low-dose prednisone. The low-risk group includes only one category of the patients, who are patients less than 60 years age who are generally well and whose disease has been stable for more than 6 months, who are on hydroxychloroquine alone. A challenging question: when to test asymptomatic CKD patients who are on immunosuppressive medications for COVID-19? This is very challenging question. There is no clear guidelines about this issue, and for the policies among different countries, it is not the same. For Kuwait, if they started screening for asymptomatic patients, I believe that the chronic kidney disease patients in immunosuppressive medications should be on the top list. How about patients who are newly diagnosed with nephrotic syndrome or vasculitis or rapidly progressive glomerulonephritis, and they will need induction immunosuppressive medication? Should we test them before giving the immunosuppression or not? It's also a challenging question, because we know that 30% of the first swab of positive patients will be negative. Whether to do or not, I think according to the current evidence, it is recommended to do test before giving the induction. So how to deal with the newly diagnosed or presenting or relapsing nephrotic syndrome in the era of this outbreak? This is the UK Renal Association guidelines for the focal segmental amyloid change disease. The standard therapy should be with steroids or calcineurin inhibitors. High-dose steroids linked to prolonged COVID-19 viral shedding and also severe disease. So whether to give cyclosporin alone or tacrolimus alone, or associated with without steroids, I mean, could be an option. This is outlined. This is outside the recommendations, but I think this is a good option based on the latest trials. If there is rapid response, consider accelerated wean from high-dose steroids, but possible longer tail through the pandemic to prevent relapse. For membranous nephropathy, we know that patients with membranous nephropathy are categorized into two groups: high risk and low risk groups. I mean risk for progression to end-stage kidney disease. So the recommendation is to delay treatment if at all possible. And if severe deteriorating nephrotic syndrome with complications, consider CNI or rituximab. Cyclophosphamide-based regimens should be avoided in this pandemic. What to do if we face the patients with newly diagnosed vasculitis or lupus? For the vasculitis, rituximab affords fewer hospital visits and less monitoring. Oral mycophenolate mofetil, MMF, can be considered in special patients who are low risk for relapse with GFR more than 15 ml per minute and without rapidly deteriorating renal function. In lupus, the oral MMF will be used as a well-established alternative to IV cyclophosphamide, which carry high risk for infection, and if possible to administer rituximab. It may be worth considering the rituximab loop protocol, which is steroid sparing. For patients with who are already on maintenance phase of immunosuppressive medications, the aim is to continue the lowest dose of immunosuppression to maintain remission but avoid relapse. And it is not the proper time to start weaning of all immunosuppressive medications in this outbreak. So the recommendation is to avoid weaning of patients with a history of frequent relapse who have been stable on low dose immunosuppression for some time and without toxicity during this pandemic. patients should stay on their maintenance immunosuppression and the steroids, provided that they are infection free. And remember that we are still speaking about negative COVID-19 patients. Immunosuppressive therapy needs to be reviewed on a case-by-case basis, balancing the risk of inadequate treating disease or acute relapse against the risk of the effective COVID-19 infection in individual patients. Patients on long-term steroid should not stop these abruptly, and patient receiving hydroxychloroquine should continue this as it may afford some protection against COVID-19, as yet unproven in clinical trials.
A randomized control trial was published in the JAMA journal this month. It compared high-dose chloroquine versus standard dose in patients with severe respiratory syndrome, coronavirus 2, SARS-CoV-2 infection. The main outcome was to test for lethality at day 13, assuming that high-dose chloroquine is associated with a 50% reduction. The secondary endpoint was to examine patient's clinical status, laboratory examination, and electrocardiogram results. Out of the pretended 440 patients that should be randomized, only 81 were allocated, half of them to the high dose chloroquine and the second half for the standard dose. Lethality was seen to be higher at the high dose group at 39% compared with 15% of the standard chloroquine group. Also, QT interval prolongation was seen more at the high dose group, and the conclusion of the study is recommending not to use high dose chloroquine with a patient with severe COVID-19 infection.
How to manage patients with suspected or having COVID-19. So, if the patient is well, not clinically deteriorated or needing mechanical ventilator or inotropic support, will continue to their maintenance medications. As we know, some of the patients are only mild symptoms. But if the condition is deteriorating or the patient develops sepsis, we consider stopping oral maintenance agents except the steroids on a case-by-case basis. When to restart? We'll start after 14 days from the onset of symptoms and 3 days after resolution of symptoms. A very important point to be considered that there is some evidence that patients who are immunosuppressed may shed the COVID-19 for longer than those without immune suppression. This may need to be taken into account when advising on a patient's time scale of quarantine after infection should be prolonged.
A paper was published from the University of Columbia addressing the management of gum nephritis in the COVID-19 era. They suggested to discontinue all antimetabolite in a patient with confirmed or suspected COVID-19 infection. They also recommended to use short-acting infusions and to avoid starting therapy for patients with marginal symptoms and stable eGFR, or not to start treatment for patients with non-standard indications. When it's possible, to switch infusions to oral forms. Also, to limit renal biopsies for only critical based decisions, and to start empirical treatment based on the pretest probability. For example, a patient with rapidly progressive GN and a positive ANCA serology. Lab visit, blood tests, and other investigations should be limited to the minimal. Also, to be advised to apply social distancing, wearing mask outside the house. Also, they suggest to activate telemedicine, phone calls, and screen patients for COVID-19 symptoms prior to visit to the hospital or to the medical facility. It's been encouraged to continue taking recommended or prescribed prophylactic antibiotics like trimethoprim Also, to continue use ACE inhibitor and ARBs unless there is clear contraindication at this point. Also, it's been suggested to complete patients' vaccinations for influenza and pneumococcus infection. Also, they have recommended starting an infusion room using the same strategies applied by the American College of Rheumatology. How to use an infusion room. So basically, it's important to postpone all non-essential infusions. Allow rescheduling so the room is not full with patients. That will allow social distancing of at least 2 meters between each patient. All staff and patients should wear masks. All patients should be checked by phone prior to their visit to be sure there is no sign or symptoms for COVID-19 infection. All equipment should be cleaned and sterilized between patients. Staff should be screened at the beginning and end of each shift for temperature, and patients should be screened by phone prior to their visit for any sign or symptoms of COVID-19 infection.
Because of the uncertainty and the cumulative incidence that cumulative evidence that abrupt withdrawal of ACE or ARBs, especially in high-risk patients like heart failure patients, will lead to adverse health side effects and clinical instability. Based on this, there is multiple guidelines, multiple societies issued their guidelines. For an example, the Australian Diabetes Society illustrated that they recommend that usual antihypertensive therapy is continued, given the speculation about risk of ACE inhibitors and ARBs is purely theoretical. And recently, the American Heart Association guidelines issued their recommendations about COVID-19 and renin-angiotensin blockers, current evidence and recommendations. They said that presently all guidelines recommend continuing ACE ARBs in patients diagnosed with COVID-19 infection until the evidence in aggregates becomes firmer, and it will. We recommended that the following with regard to COVID-19 and RAS blockade. In non-infected patients and patients at risk, there is currently no valid reason to discontinue RAS blockade. In healthy subjects at risk, evidence is not yet sufficient to prophylactically recommend RAS blockade. If apprehension about increased infectivity persists, patients on ACE or ARBs could temporarily be switched to a direct renin inhibitor. In COVID-19 positive patients on RAS blockers, the drugs should be continued. In febrile patients with pulmonary symptoms, RAS blockers close monitoring of blood pressure and renal function is advisable. RAS blockers should be discontinued only as clinically indicated. We know from KDIGO guidelines that for septic patients, they are at risk of acute kidney injury because of intravascular volume depletion, and the use of ACE or ARBs in this situation may accelerate the instance of acute kidney injury in those patients. Whether to continue ACE or ARBs in those patients with COVID-19 positive, I think if they are clearly septic, we may stop the ACE and ARBs in that situation until there is evidence. Again, there is evidence supporting the benefit of ACE and ARBs in protecting the lungs from COVID-19 infection.
2 studies were published recently in the New England Journal of Medicine examining the effect of ACE inhibitor and ARBs on COVID-2 infection. The first study was a population-based case control study from Lombardy, Italy, and it compared 6,700 patients or case patients with the standard beneficiaries of the regional health system as a control, and according to the age, sex, and municipality of residence. The use of ACE inhibitor and ARB were more common in the case group as compared with the control group. Also, the use of other antihypertensives and non-antihypertensive medications. Also, the use of ARB or ACE inhibitor did not show any association with COVID-19 among case patients overall, or among patients who had a severe or fatal course of the disease. So despite a larger use of these medications in the case group, there was no evidence that the use of ACE inhibitor or ARB affected the risk of COVID-19 infection. The second paper was from Harvard, and it was an observational database from 169 hospitals in Asia, Europe, and North America, of total 8,910 patients with COVID-19 for whom discharge status was available. Of these patients, 515 died, which is about 5.8%, and 8,395 patients survived to discharge. The odds ratio that associated with increased mortality include age above 65 years, coronary artery disease, heart failure, cardiac arrhythmias, COPD, and current smoking. The odds ratio of using ACE inhibitor or ARB did not increase, and there is no evidence that these medications increase mortality. So the study confirmed previous observations suggest that underlying cardiovascular disease is associated with increased risk of COVID-19 associated in hospital death, but there is no evidence of potential harm from the use of ACE inhibitor or ARB.
So, if we face patients with kidney transplant patients in the casualty with suspected or confirmed COVID-19 patients, we will contact our colleagues at transplantation team in Hamad Al Isa Center and decide with them whether it's better to keep the patients in our hospital or transfer the patient to their certain. This is according to their protocol and their policy. If the patient admitted to our hospital, we will evaluate the patient, and then we will discuss with the second call transplant nephrologist and Hamad Al Isa about the proper way to manage the patient and what to do with the immunosuppressive medications. And they don't need to come to the hospital. We will evaluate and they will contact them by phone. There is also the Renal Association guidelines, and the British Transplantation Society issued guidance on the management of transplant recipient diagnosed with or suspected of having COVID-19. This is issued this month. First, patients in the early phase may have false negative nasopharyngeal swab results, as we mentioned before, about 30%, and repeat nasal swab may be required. A first result is negative and the clinical suspicion is high. This is the British guidelines, and we know they are not admitting every patient with COVID-19 to the hospital, but here in Kuwait until now, every patient with diagnosed with confirmed COVID-19 will be admitted to the hospital, but they are recommending the indication for admission at hypoxia, significant chest X-ray findings, and tachypnea. And the indications for poor prognosis are the older age, elevated CPR over 125, neutrophil to lymphocyte ratio over 3:1, significantly elevated troponin, elevated D-dimer, platelet count less than 100, and elevated ferritin. What to do with those patients regarding the immune suppression? The transplant, regarding the diagnosis and the immune suppression, transplant patients with symptoms compatible with COVID-19 should be dealt with the local guidance for use of PPE, and will assess the patient to swab for SARS-CoV-2, and also don't forget to exclude other causes of symptoms like CMV, pneumocystis, community-acquired pneumonia. For patients who do not require hospital admission according to their policy, the British policy I mean, they will stop the anti-proliferative agents, MMF and AZA, and review total burden of immunosuppression, and they consider reduction of CNI. For those who are unwell and admitted to the hospital, they will stop the anti-proliferative agents, consider reducing or stopping the CNI, consider increasing steroids if currently taking them. There is no evidence for benefit of the high dose steroids at this stage. For the sepsis campaign guidelines, they are recommending to give hydrocortisone at a dose of 200 mg per day. For patients who are progressively unwell and require ventilatory support, they recommend to stop the anti-proliferative agents, dramatically reduce or even stop the CNI, consider high-dose steroids in this situation after discussion with the ICU team, ventilatory support, and antiviral therapy. And remember that if and I don't think so, that the CNI is continued in this stage, some of the antiviral medications have an effect on the level of the tacrolimus and cyclosporin. So the final topic of this presentation is how to manage the inpatient dialysis surface. Dr. HEMEDA spoke about the acute kidney injury pathophysiology and management of through the era of COVID-19 pandemic. I will take some practical points in this talk. Recently, the ICRRT report on COVID-19 critical care patients in UK issued their report 1 week back. We can see from this figure that the incidence of patients admitted to the ICU and the needs renal replacement therapy is about 18.5%. This in comparison with 15.9% with the patients with other viral pneumonia in the period between 2017 and 2019. But the problem is that the mortality among those patients is very high. We can see from the second figure that the mortality among patients receiving renal replacement therapy in the ICU and patients who are COVID-19 positive is almost 18%. This is in comparison with 43.6% in patients who are not receiving renal replacement therapy. So what we will do for evaluation of AKI in hospitalized patients, we will evaluate routine patients as any other patients. As we know, we have extensive experience about dealing with critically ill patients who developed acute kidney injury in our hospital, and we will deal with them as routine. What is different here that we will try to avoid daily patient contact as much as we can. To evaluate the volume status, which is a very critical issue in those patients, we should focus on the following. First, we should know the cumulative fluid balance, and this is registered in the ICU system here in our hospital. It is easy to take it, to know it. Second issue, look at the CVB and the pulmonary capillary wedge pressure, look at the chest X-ray, and discuss with the ICU team regarding their clinical evaluation. Also, we should avoid the hypervolemia, and we will discuss later about this specific issue. You should review medications, and those patients will receive antiviral medications which may have an adverse renal effect. Also, they will be put on antibiotics, and it is advised strongly that we should stop the use of the nephrotoxic antibiotics, especially the vancomycin and colistin, except if they are culture-based, to avoid the unnecessary acute kidney injury in those patients. And finally, there is unusual causes of the AKI if we fail to determine the cause of the AKI. This figure, which was shown in the Dr. HEMEDA presentation about the potential mechanisms of the acute kidney injury in the era of COVID-19 patients, we have the cytokine release syndrome, and also the secondary hemophagocytic syndrome. To differentiate between both, you should look at the serum ferritin level, which is shooting in case of secondary hemophagocytic syndrome, and also the bone marrow diagnostic for sure. Also the cardiomyopathy or viral myocarditis, and there are recent articles speaking about the increasing instance of viral myocarditis in those patients. The rhabdomyolysis, as we see in the figure in the left side, that they saw in the United States a lot of patients with rhabdomyolysis secondary to COVID-19 infection. Also the positive fluid balance, we will speak about this. Other causes to be considered, we have the intra-abdominal compartmental syndrome, the volume overload, acute rhabdomyolysis, as we mentioned. Many patients will be sedated, and there may be a propofol toxicity. We should put it into consideration. Patients with rapidly deteriorating severe metabolic acidosis, we should ask for the osmolar gap for possible ethylene glycol toxicity from the diazepam. Also IVIG, which is not recommended for the time being for COVID-19 positive patients. It carries the risk of acute kidney injury, and also, as we mentioned, antiviral induced. The effect of volume overload, we know that increased 10% of the basal body weight can cause acute kidney injury. This is because of the increased renal venous pressure, and which can cause and also renal interstitial edema, which will reduce the renal blood flow. So, how to manage the acute kidney injury in hospitalized patients? For patients with AKI that is not dialysis requiring, we should limit contact as much as possible, as we mentioned before. Physical examination should be coordinated with the primary consulting team to minimize contact when possible. Fluid resuscitation goals are understandably conservative as per various acute respiratory distress syndrome criteria. A very important issue here is the fluid therapy. For patients with sepsis in the early stage, not the late stage, before developing ARDS, what seems to be ARDS actually, we should be cautious in giving the IV fluids. First of all, we should deal with fluids as we are dealing with any other medicine, balancing the risks and versus the benefits. So we will deal with what is called four phases of fluid therapy, which is rescue, optimization, stabilization, and de-escalation. For rescue, the aim is to correct the shock. Then we should optimize and monitor tissue perfusion for the optimization phase. Then for the stabilization phase, we are aiming for zero or negative fluid balance. Then de-escalation, aiming to mobilize the fluids accumulated during the illness. We'll use crystalloids, not colloids, and balanced crystalloids is favored over non-balanced crystalloids. For patients with dialysis requiring AKI, dialysis will be bedside, and we will allocate machines for the ICU positive patients and also for the ward positive patients, and those machines will not be transferred from the ward, and also the patient will not be transferred. And dialysis should be ideally be performed in the patient hospital room with the door closed. So our targets for dialysis in the dialysis for inpatient dialysis, I mean in the ICU or in the ward, our targets will be improving the patient outcome. Second, ensure staff safety, and third, reserve our consumables. And for that, for the CRRT prescription, the indication for dialysis, we know that there is no, until now, based on the current evidence, there is no difference between early initiation versus late initiation of dialysis regarding the mortality. So we will stick to our policy and what you are doing over the last years, that you are dialyzing patients if urgently indication for sure. And for those patients with volume overload or ARDS, we will give bolus Lasix. We'll give 160 milligram to 200 milligram as a bolus according to the patient's body weight. If there is good response illustrated by increasing their output to more than 0.5 ml per kg per hour, or ideally more than 100 ml per hour, we'll continue Lasix aiming for negative fluid balance. Or otherwise, if there is no response, we'll start dialysis. And also, if the patient is not overloaded, no urgent indication, but no anticipation of soon recovery, we will not wait until the patient will be overtly uremic, except if we are faced a lot of patients will stick to the clear indication for starting dialysis. The mode of dialysis, as we are doing in the ICU, will do CVVHDF, and for the inward, we'll use the NX stage machine. To reserve our consumables, to reserve the filters, we should use anticoagulation unless contraindicated. We know that now they are categorizing the patients with COVID-19 for low risk and high risk regarding the hypercoagulable state. And for low risk, they are giving prophylactic anticoagulation. For the high risk, they are giving therapeutic anticoagulation. And among the patients with high risk for hypercoagulable state are the AKI patients or patients needing renal replacement therapy. So we will discuss with the ICU team regarding whether they will put the patient on therapeutic anticoagulation or not. Otherwise, we will use unfractionated heparin with monitoring of APTT, or we can use low molecular weight heparin with monitoring of the anti-factor XA level, which is available in our hospital. Another issue is we should calculate the filtration fraction before when we are prescribing the order for CRRT, and we should keep the filtration fraction below 25% to decrease the incidence of filter clotting. We should also try to reserve our fluids. We will stick to 8 to 10 hours of CVHDF, except in selected cases who may need extension of that order. And the dose will be 35 ml per kg per hour as prescribed dose to achieve the delivered dose of 20 to 25 ml per kg per hour. We know that the ASN issued the recommendations about using high dose in those prolonged intermittent renal replacement therapy, about 40 to 45. But actually, over the last 10 years, we are using this 35 ml per kg per hour as prescribed dose in our patients, and we were able to achieve our targets using this prescription. And we should precise calculating the dose before starting. So the targets of dialysis here will be, we should put the patients in a steady urea state with urea from 20 to 25 to avoid the harmful effect of the urea of the uremic state, and fluid removal to target, and we will speak about this soon. And we should monitor the electrolytes and the acid base, aiming for normalization of the electrolytes, especially potassium, magnesium, and phosphate, who are supposed to go down with the dialysis. How to deal with those patients with COVID-19 patients in the ICU? Recently, the Surface Sepsis Campaign issued their guidelines on the management of critically ill adults with coronavirus 2019. We will take this 3 recommendations. The first, that healthcare workers providing usual care for non-ventilated COVID-19 patients, they suggest using surgical medical masks as opposed to respiratory masks, in addition to other personal protective equipment. For healthcare workers who are performing non-aerosol generating procedure or on mechanically ventilated closed-circuit patients with COVID-19, they suggest using surgical medical masks as opposed to respiratory masks, in addition to other personal protective equipment. Also, for adults with COVID-19 and shock, this is very important, they suggest titrating vasoactive agents to target mean arterial pressure of 60 to 65. We know that our targets for our patients to preserve the kidney function and to preserve renal blood flow, we are always advising that the target mean pressure to be more than 65, especially if the patient with established chronic hypertension before. Why they are recommending not more than 65? Because the increased incidence of adverse effects with increasing the doses of the vasopressors to achieve this target, especially the arrhythmias. And very important here that they are, for rationalization of their recommendations, they are stating that the optimal fluid strategy in COVID-19 is not known. However, it is possible that these patients will respond to fluid similarly to other ARDS patients. So we will deal with those patients upon the current evidence as we are dealing with the ARDS due to other causes. We know from the Critical Care Nephrology Core Curriculum 2020 and that the conservative fluid strategy according to FACT trial is associated with more ventilator and ICU free days, and we should aim that both those patients with an ARDS due to secondary to COVID-19 infection to negative fluid balance with target CDP less than 4 and pulmonary capillary wedge pressure less than 8. And for those patients with AKI on ECMO, CRRT is the preferred modality, and you are doing this over the last years here in Adan Hospital. And it can be provided by placing a separate dialysis catheter or connecting the CRRT circuit directly to the ECMO circuit. A separate dialysis circuit may lower the risk of embolism in the ECMO circuit, but separate circuits also have the practical advantage that the problem with one circuit will not interfere with the other. When we started to do dialysis CRRT in our hospital, the Adan Hospital, we discussed with the ICU team about the preferred method, and we agreed both that we will use separate line because to reserve the ECMO line, which is actually very expensive. So we are using separate line for ECMO, separate line for dialysis. The vascular access regarding the temporary for the acute kidney injury patients, jugular versus femoral. If the patient is in prone position, let's be referred to put the patient in jugular. If the patient is not in prone position, whether to insert femoral to decrease the incidence of infection, there is no evidence about that. But it is very important to make sure that the catheter is adequate. And for end-stage renal disease patients, if we are using the NX-stage machine, we can use the AV fistula. This is in the ward, but in the ICU, using the Prismaflex CRRT machine, if we are using for 8 hours, we can use the fistula, and we use it before in the ICU. But if those patients needing prolonged time of dialysis, it is better to avoid dialysis through the fistula. For the ward dialysis, we have the hemodialysis patients and the BD patients, and Dr. Muhammad Kamal spoke about how to deal with those patients on outpatient basis. But if those patients admitted to the isolated ward in the hospital for COVID-19 patients, for BD patients, if they are stable, we will put them on ABD. But if they are worsening respiratory condition, and we will shift them to hemodialysis. For hemodialysis patients, we'll use NX stage machine for them. In the outbreak, if we are facing a lot of patients admitted for COVID-19 patients, we may consider decreasing the dialysis to be twice weekly instead of 3 times per week, and we may also decrease the time of dialysis. For the drained dialysate, for the BD and for the next stage, this is very standard protocols, and it is recommended during that to wear the recommended PPE. For safety issues, if possible, dialysis staff should limit time in the room with the patient. In the ICU, we know that we can monitor the patient from outside through the glass, and the dialysis effluent from suspected or confirmed COVID-19 patients can be disposed at bare standard our protocol, and also as in the ward they should wear the complete recommended PPE. The CRRT machine should be cleaned and disinfected by routine procedure before moving it outside the room. For the staff safety, the nephrologist, as you mentioned, should limit contact as much as possible, and the CRRT done in the ICU by the ICU nursing team. We may consider one nurse for more than one patient, and here is this figure illustrating that we can put the machine outside the room by using extension. This line extension on the left side, this is the routine regular dialysis line connected to the catheter. Then the line of the PrismaFlex connected to the line. And finally, for the shortage plan, if we face a shortage, and we hope that we will not face this situation, we hope that we will pass with this pandemic, this outbreak, with the very limited number of patients in Kuwait. We hope so. But if we face such situation, there is our strategy will reduce the time and dose of dialysis. We will prepare the CRRT replacement fluid, and we have already, as it is shown in the figure, that replacement fluid recipe. And for the ABD as a modality for the acute kidney injury, and actually we have this webinar which will give us a great opportunity to find out how to use this forgotten modality for acute kidney injury, and to watch the premiere of the ISCBD guidelines about that. Thank you. For any queries, please do not hesitate to contact me on the provided email. Thank you.